Okay, so today we're going to talk about the bundle branch blocks. There's two of them. There's a right-sided bundle branch block and a left-sided bundle branch block. So let's start off with the left bundle branch block. In the left bundle branch block, you have a QRS prolongation of greater than 120 milliseconds. You see here the QRS is pretty wide, and QRS is pretty wide, and QRS is pretty wide. It's greater than 120 milliseconds. Then you have a broad R wave in lead 1 and in lead V6 with no Q waves. You don't see a Q wave in lead 1 and in lead V6. And then you have a broad S wave in the septal lead, which is lead V1. So you have a broad R wave in lead 1 and lead V6, and a broad S wave in lead V1. You can call it either broad or you can call it deep, but it's a deep S wave in V1. So what is the definition of a bundle branch block? And you have the left side bundle branch block and the right side bundle branch block. So what happens is that when you have a left-sided bundle branch block, that means that this entire bundle branch is not working. And this is the bundle of His, and then this is the Purkinje fibers. So what they just say is that this is the left bundle branch. It's the entire branch. And so when you have a left bundle branch block, this entire left side bundle branch is not working. So what happens is that when the impulse signal comes from the SA node to the AV node, it goes immediately to the right side because the right side is intact, and so it functions properly. And so after it hits the right side completely, then it makes its way over through the septum to the left side, and then it depolarizes the left side. And then in right bundle branch block, the same thing is happening, but just opposite. And so what's going on is that the right side is completely blocked off and it's not working. The right bundle branch is not working. So what happens with the signal, the impulse comes from the SA node through the atrium to the AV node, then it's going through the intact left side. It's working in the left side because the left side is working on a right bundle branch block. The left side is working, and the right bundle branch, just like it says, has a block. On the left side, the left bundle branch has a block. So if the right bundle branch has a block, then the signal is going through the left bundle branch, and it depolarizes the left ventricle, and after that, then it makes its way over back through the septum and into the right ventricle. And so there's a delay in the depolarization of the right ventricle. And so let's talk about left bundle branch block. So in left bundle branch block, you have the left bundle branch is completely blocked off. It's not working, just like it says left bundle branch block. So what side is working? The right bundle branch does work. So the right bundle branch is working. So when the signal comes from the SA node, it goes through the atrium and comes to the AV node, and instead of going to both bundle branches normally, now because the left bundle branch is blocked, it's going to the right bundle branch, and it as soon as it hits the right bundle branch, then after that there's a delay, and it makes its way over from the septum to the left bundle branch, and now it depolarizes the left bundle branch. And so in left bundle branch block, when the signal goes from the SA node to the AV node, it makes its way down to the right bundle branch, and I put two leads here, the V6 lead here. The V6 lead goes towards this side of the heart, and then the V1 goes to this side of the heart. And so we see that when the signal makes its way down, there's an early signal that makes its way to V6. You see it's coming towards V6 little by little. So there's a wave that shows that in V6. And so that early signal here towards V6 is called the small R wave. And so as that signal makes its way away from V6, when it's making its way away from V6, then you see a decline because it's going away from V6. And so when the signal makes its way to the remainder of the right bundle branch, then after that, because the left hasn't been depolarized at all, the signal goes towards the septum and then depolarizes the left bundle branch. So you can imagine on a normal process, the signal comes here and it depolarizes both ventricles at the same time. But when there's a left bundle branch block, it depolarizes the right side first, and when it's done, because the right side is intact, there's no damages on the bundle branch. Then after that, it makes its way over to the left side and eventually depolarizes the left side, but it happens slowly, and because it doesn't happen simultaneously, there's a delay in the depolarization of the left ventricle. So as I mentioned, the small R wave happens when the signal comes towards V6, and then when the signal goes away from V6, you have a decline. So a short incline, a decline, and then during that delay, when the signal, after it depolarizes the right ventricle, then it finally makes its way over to the left ventricle, and it's coming towards V6. So there's a sharp incline again, and then it fades out. And so this second wave is a tall R wave because it's the delayed depolarization of the left ventricle. So if you see, this thing looks like something. It looks like bunny ears or rabbit ears, and they call it the RSR wave, the RSR wave. And you see that you see that happening here. And this same phenomenon happens in V6, and it happens in lead 1. So like I mentioned before, the left bundle branch block has a QRS greater than 120 milliseconds. This QRS is greater than 120 milliseconds. The RSR waves, like I said, the bunny ears, are in lead 1 and in lead V6 with no Q waves. So see right here, the bunny ears. If you notice that, those look like bunny ears, but it's the RSR wave. And then you also have a characteristic of broad slurred S waves in V1. So this is a very deep slurred S wave in V1, and these are the characteristics of left bundle branch block. So common reasons for the damage of the left bundle branch block is due to obstruction or infarction of the left anterior descending artery. If there's an infarction of the left anterior descending artery, that can create a problem with the left bundle branch block. And if a left bundle branch block occurs because of the infarction to a left anterior descending artery, then that damage is pretty much permanent, and it typically results in difficulty in reading in any future EKGs. And left bundle branch block may also be damaged. The left bundle branch may also be damaged. The left bundle branch block may occur by diseases which cause diffuse damage to the left ventricle. So the diseases that cause diffuse damage to the left ventricle, as you can see, the bundle branch is in the myocardium. So if there's diseases in the left ventricle that are affecting the myocardium, it's eventually gonna, if it's severe enough, it's eventually gonna affect the bundle branch. So some of the diseases are hypertension, myocarditis, cardiomyopathy, and left bundle branch block can also be seen in diseases of the aortic valve. So as you see here, there's an aortic valve that's very close in anatomy to the bundle branch, the left bundle branch. The aortic valve is very close in anatomy. So if you have diseases of the aortic valve, they can also cause left bundle branch, because the left bundle branch is very close to the cusp of the aortic valve. And such diseases are endocarditis, aortic stenosis, aortic valve regurg. So now let's talk about right bundle branch block. Right bundle branch block is now the same thing, but it's the opposite. Instead of the left ventricle, it's affecting the right ventricle, the right bundle branch. And so The characteristics are the QRS is greater than 120 milliseconds. Same thing as left ventricle, left bundle branch block. The QRS is greater than 120 milliseconds. The rabbit ears, the RSR wave is now in V1. So in V1, you see these rabbit ears, the rabbit ears, the rabbit ears I had shown earlier. These occur in V1, and then there's a slurred S wave in V6. You see a slurred S wave in V6. So you see here this broad and slurred S wave. You see that in V6. Now we'll talk about the same morphology that I talked about earlier for left ventricle. Now the right bundle branch. In a right bundle branch blocked, the right bundle branch is blocked. So the signal going from the SA node to the AV node now goes only to the left bundle branch because it's intact, and then after it makes its way from the left bundle branch, then it makes its way from the septum to the right bundle, to the right ventricle, and it depolarizes the right ventricle. And so imagine if it's the normal impulse would go to both ventricles at the same time. Now because the right bundle branch is blocked, the impulse goes first to the left ventricle, and after it depolarizes the left ventricle, then it makes its way over to the septum and depolarizes the right ventricle. So that causes a delay. And so in V1, and so repolarization in the right ventricle is delayed, and this creates a wide R wave in V1. And the S wave is produced due to the delay of the impulse moving from V6 creating a late slurred S wave, and we can see that S wave in here. So you see in V6 there's a late slurred S wave, and that can be seen in right bundle branch block. And you see here the QRS is wide, showing a delayed in the right ventricular depolarization. The QRS is wide. And so in right bundle branch block, you see here the right bundle branch, compared to the left, you know the left ventricle is much bigger, much stronger, contracts stronger than the right ventricle. So the right bundle branch is it's a very thin filament. It lies very close to the subendocardial surface of the right ventricle, so it can have damage easily when there is an increase in right ventricular pressure. Damage can happen easily to the right bundle branch, and such damages can occur due to pulmonary hypertension, pulmonary embolism. And the right bundle branch is supplied by septal branches of the left anterior descending artery. So an anterior myocardial infarction of the resulting from an LAD can lead to right bundle branch block. A anterior myocardial infarction. The right bundle branch is supplied by septal branches of the left anterior descending artery. So an anterior MI can lead to a right bundle branch block, and it can result from a myocarditis and cardiomyopathies. And so in regards to left bundle branch block, we're talking about treatments. In regard to left bundle branch block, some patients with left bundle branch block and markedly prolonged QRS and congestive heart failure may benefit from a pacemaker, which provides rapid left ventricular contraction.